Welcome to Smart Life. My name is Dr. Jose Mena. I'll be your host in today's show. Today, I'm joined by my colleague, Dr. Georgiy Brusovanik, spine surgeon. I'll be talking to you about questions and concerns about back pain. So I have Dr. Brusovanik here on my other line. So we'll be talking about if all spine surgeries are the same.
Dr. Mena, thank you so much for having me on the air with you. That's a hard question. I think there are some elements that are common to all surgeries, yet every operation is different. Every patient is different in some way. Of course, I would say in the end, spine surgery can be categorized into really two types. There is a type of surgery that's meant to remove compression from the nerves. Let's call that decompression surgery. And then there's surgery that's meant to fix deformity. So you have a building leaning and you straighten it up and you fix it into place. And that's called a fusion surgery. Now look, there's some other options in between, like disc replacement, for example. But for the most part, I think that's a very good way to look about spine surgery. Decompressive versus fusion surgery where you have to put screws and rods.
And that's actually one of the questions that a lot of patients they face when you do a microdiscectomy or when you do a fusion, when you do a decompression. What are the most common indications for this type of surgeries?
So look, this is a very interesting question because nomenclature or what we call things makes a big difference. Now, let's say you have back pain and you get an MRI. And your MRI says that you have a degenerative herniated disc. Does that mean that you need a microdiscectomy? Because look, there are different kinds of disc herniations. For example, imagine a disc is a big circle, like a jelly donut. And if that jelly donut tears, then something comes out and it starts to press on the nerve. Patients experience this terrible pain going down their leg. A lot of times that's referred to as sciatica. For that patient, a microdiscectomy will do wonders. You can sneak in, remove that little piece of disc and sneak out. Now imagine that same situation where the disc hasn't really torn, it just became wider. Now, in that situation, if you go in and you do a little cutout of the disc, you'll make it worse. It's like making a bigger hole in a flat tire. So I would tell you the short answer for microdiscectomy, it's a specific type of a disc herniation that deserves that operation. And the patient who is really suffering and saying, I can't live like this, it's just too much pain to tolerate.
And those surgeries for the audience, actually, because I get those questions, how quick those surgeries are. Are they quick? How do they require an inpatient stay?
The operations are quick. It takes about an hour, but it's hard for a patient to know which is the one that they actually need. I think a lot of it depends on the experienced eye of the spine surgeon looking at the MRI, not just reading the report and saying, okay, this is something that I can improve versus this is something that will get better with injections. And as you know very well, vast majority, Dr. Mena, get better in your hands with the high quality epidural injections that you perform. So most of the time, it is not a surgical problem.
No, correct. We get that a lot, and very small subset of patients actually they go into surgeries. But the question is from most patients, what will be the recovery time? How long they can go back to their daily activities after they undergo this type of surgery?
So a properly indicated discectomy is a very rewarding operation. Usually, patient wakes up after surgery and says, my pain is gone. If that night they hit all their milestones, they can eat without feeling nauseous, and their pain is under control, they can go home. A properly performed minimally invasive discectomy where no muscles are injured, that patient does not need much in the way of recovery. That patient does not need much in the way of physical therapy. That patient essentially can get back to their work within 2 to 3 weeks.
Correct. And actually, we also get from patients, actually, what are warning signs that you require a specific surgery like this? Because some patients, they come into the ER and they say, well, you need surgery. And sometimes when we see this type of patients, then of course, those patients, they don't require any surgery. They might get better with an epidural injection. But what are the warning signs that you say, yes, this patient needs a surgery right now coming from the ER setting rather than waiting at conservative care?
Great question, Dr. Mena. So 2 things. One, it's that MRI with a type of a disc herniation that a surgeon can improve. The other is the clinical picture. It's a patient who's dying in pain or a patient whose nerve is sick. Now, what does that mean? A sick nerve means that the patient is experiencing pain, numbness, and weakness in the same distribution, the same direction as where that nerve travels. So for example, pain going down to the big toe, difficulty lifting the big toe and lifting the ankle, and numbness in the same region are a significant combination. To me, these are the worst warning signs that a patient will likely need an operation.
And let me ask you, what are the main complications from surgeries whenever you do a microdiscectomy? What will be your worst fear from those patients?
You know, I wish more patients would ask me that question, Dr. Mena. I always end up volunteering that information, but if you don't go to me for spine surgery, ask your surgeon this very important question above all else. What kind of complications have you seen, doctor? What have you done about it? Look, the biggest issue with a microdiscectomy, where you remove a little piece of disc, is that another little piece can come out from the disc proper and occupy that space to a tune of 9%. Now, we've done studies in the past in combination with neurosurgeons where you can remove more of the disc to see if maybe that will decrease the risk, but that just causes more back pain. So the reality is that there's no way to get away from the disc. It's a small, elegant operation, but that risk is important to discuss. And if you do have a reherniation, there's even a chance that you may need to go back into surgery, but that wouldn't be the first step. If you really reherniate, then you try injections once again, and most of the time, as in like 90, 89% of the time, these patients do get better on their own. Look, the risk of complications in totality is long, but that's probably the biggest one because truthfully, for microdiscectomy, infections, bleeding, you shouldn't hear about that. These are complications that would be sort of like the never events.
Let me ask you as well. There's some patients, they come into office, they have a horrendous MRI. The same warning signs that you're saying, like have a big toe is dropped down, they are unable to walk. And some of those patients they're begging me to do an injection. I tell them, listen, you have a significant amount of neurological compromise. You need to see a spine surgeon. What will be your take on those patients? Do you agree with me, or you think about doing an injection on those patients, or you go ahead and do the surgery?
This is a very tough ethical question. You know, in the end, I have to say, what would you and I do if this was our family members? Now, if this was my family, I would be very, very direct with them, almost too direct in saying, look, if you don't do something, you may have permanent damage. But the reality is that that probability is very low. And surgery has real life-threatening risks. Now, if you can tolerate the pain, don't do surgery. If you can tolerate the numbness, you won't die from the numbness. So surgery is always the last resort, and it's really only if the patient says, I just cannot live with these symptoms. For 95% of the cases, that's the reality.
Thank you so much. And actually, thank you for joining me today in the Smart Life. It has been a great conversation. Hopefully, a lot of these patients will be able to understand and be able to be fully educated, because that's at the end, we're taking care of the patients and we definitely want to do the best for them. Thank you so much.